Okay. Hi everyone, thanks for joining. It's just a couple minutes, we'll get going. Just wanted to say hi and thanks so much for joining. Give us a few minutes and then we'll get started with the presentation. All right, everyone. Well, it's 5:30. Thank you so much for joining us tonight with Dr. DiFiore to talk about building your bone health. I'm very excited to introduce Dr. DiFiore, but before I do that, I just wanted to share a couple of things. If you have questions throughout this, please put the questions in the Q&A. If you do have concerns right now and you can't hear, or if there's some technical difficulties, just put that message in the chat and we'll go ahead and hopefully get you sorted out with that. We are recording this this webinar, so this webinar will be available afterwards if you want to review it. And Dr. DiFiore has given us the okay to be able to send the slides out as a PDF afterwards, so you can let us know if you would like the slides. So with that, are there any questions? And if throw it in the chat if anyone's having any technical difficulties. I see a Q&A. Okay, I see a question right off the bat. Please talk about reclassed infusion. It's scary to me. So Dr. DiFiore, that's our first Q&A. So now we know the Q&A works, so that's good. All right, well, it looks like I don't have any other questions. So what I'm going to do is I'm going to stop my screen share. And then that way, hopefully we can view everybody. All right, with that, it's my great pleasure to introduce Dr. Michelle DiFiore. Dr. DiFiore graduated from Chicago Medical School in 2015 and completed her internship and fellowship at UC Irvine Health. She grew up in Gilroy and returned to Santa Cruz 2 years to practice rheumatology. 2 years ago to practice rheumatology. Dr. DiFiore became a physician to help patients find ways to feel well so they continue doing the things that bring them joy. Given that the many rheumatological diseases are complex with a variety of new treatment options, she feels it's important to educate patients on their disease and incorporate shared decision-making to help find the best individualized treatment plan. Dr. DiFiore's personal interests include spending time at the beach, hiking, cycling, traveling, going to concerts, and spending time with family and friends. Please join me in welcoming Dr. DiFiore.
Thank you, Karen. Really appreciate it. All right, let me see if I can seamlessly get my screen to share. All right. And then, all right. So hi, everyone. I'm Michelle DiFiore, and I'm really excited to talk to you today about osteoporosis. I really modeled this talk around a lot of questions that I get in clinic from patients. So this is kind of the goals of the talk. What is osteoporosis? We'll talk about who gets screened and the indications to screen. Then we will talk a little bit about interpreting bone density reports. There's a lot of information on there, a lot of statistics, and just some tips to understand it when you get your report back. We'll talk about preventative treatment and medication options, including reclass and some of the side effects of the medications. So first off, what is osteoporosis? So it's a skeletal disorder characterized by compromised bone strength. So bone strength includes bone density and bone quality, and we use the bone density machines to, assess bone density. But there's other things that go into bone quality and other risk factors that we'll talk about later that also, is involved with the strength. On the picture here, you can see a normal bone. So you can see that the connections between the different areas, they're pretty thick. It's a little spongy, but you can imagine that compared to the right side, these connections are weak. You can see one's already broken and wouldn't be able to withstand a lot of stress. So that would lead to fractures. And the term osteoporosis literally means porous bone. And what I tell my patients is it's usually asymptomatic until it's not. So the whole kind of goal is to prevent fractures. So typically osteoporosis, when we're doing screening, you might not know that you have it, but the goal is to prevent fractures that can be very painful and debilitating. This slide is to kind of show a little bit about bone density and peak bone density. So we're growing, our bone density really peaks around our 30s. Different areas of our spine and our arms, legs, they kind of reach peak bone density at different points in our late 20s and 30s, but typically by the age of 30, we're at our peak bone density. And different factors can change that for each person. A lot of it is hereditary and genetic. Other things, if someone's a smoker, they drink a lot, and if they were on other medication or hormones at a younger age, that peak might not be all the way up here. It might be a little bit flat. So you might start off a little bit lower. But once we get to the age of 30, there's really no preventing it. Our bone density will decline. And this shows, compared to males, you can see males have a slow, steady decline. However, estrogen kind of protects our bones as women. And once we reach menopause, you can see this large dip in our bone density. So a lot of the screening happens in our 60s to look at where that bone density is and to assess for osteoporosis. So why do we lose bone? Our bone is constantly being remodeled. So you have both osteoclasts and osteoblasts. They're two different types of bone cells. Osteoblasts build bone, osteoclasts break it down. And it's like homeostasis between the two. However, when the osteoclasts take over, and that is more than the building of bones, then you have a decrease in bone formation. And I just wanted to kind of highlight that there's different areas of different rates of bone loss in different areas of bone. So this picture is a picture of a femur, and you can kind of see the spongy cancellous bone is in the center, and then you can see the dense cortical bone on the outside, and different types of bones in our body have different ratios of that. In the hip, there's more cancellous bones, and that you lose pretty fast, more in your 60s. And that's kind of why we see hip fractures around that age. Places like the forearm is more cortical bone, and that's, wrist fractures happen, and it's kind of a steady incidence over time. And it is important to know that fractures increase with age, and it varies by these different sites. So kind of schematic of this, you can see hip, it happens more in our 70s, mid 70s to 80s. The wrist, you can see it because it's gradual over time. Maybe people are more active in their 50s compared to their 80s to 90s, but it happens. So that might be a reason why it happens when you're younger. But overall, fractures do increase with age. And this kind of is a little bit more information about, where those hip fractures happen. But you can see most of this information is about the spine and hip. I did want to kind of talk about the common sites of fracture. So out of all the fragility fractures, vertebral fractures are about 27%, wrists are 19%, and hip and pelvis are a little bit lower, but 14 and 7. Vertebral fractures are, you might have heard of them be called compression fractures. So these can be asymptomatic. So sometimes patients will be getting a chest x-ray and they will find, you can see the spine in a chest x-ray. They got it for pneumonia and, oh, you have a compression fracture in your spine. Same thing on like CT scans, or maybe they were getting a low back x-ray for back pain and it ends up being that there was an old compression fracture. Sometimes they can be very symptomatic. So if bone density is very low, I had a patient in my training. He was an asthmatic, was on prednisone for a long time. He had decreased bone density. He was coughing and coughing and coughing so bad that he had acute back pain. And when we got an x-ray of his spine, he did have a compression fracture. So they can be pretty painful when acute. So those are the ones that can vary between symptoms. Wrist, you're walking, falling on an outstretched arm, that's going to be painful. And then hip and pelvis, we'll talk a little bit more, obviously slipping and falling. And this kind of what leads to a lot of people to go to the hospital with fractures. And then this will come up again, but I did want to define what a fragility fracture is. So we talk a lot about fractures in osteoporosis. Fragility fracture is a fracture occurring with minimal trauma, such as a force equal to or less than falling from standing height. So, if you were in a car accident or on a skiing trip and you broke your femur, there's a lot of force happening with that. And our bones may not be able to withstand that force. However, if you were walking to your kitchen and slipped over the rug and fell on your hip, our bones should be able to withstand that force. So the fragility fractures are the ones that are kind of highlight and raise the flag in our minds of, hey, our bones should be able to withstand that force, and it's because the bone is too fragile. So those are the ones that we really want to prevent and can be an indication for treatment. So why is this so important? It's very common in the US population. 10 million Americans have osteoporosis, and the majority of them are women because it does happen after menopause. In particular, although hip fractures are not the highest type of fracture seen in osteoporosis, they have a high rate of mortality and morbidity. So depending on the age, 1 year mortality can be up to 25% for hip fracture. And so if you think about it, when you fracture a hip, a lot of your mobility is lost. You're in bed, depending on how severe the break is and how the surgery went. You're not moving, you're at higher risk for blood clots. You can get bed sores, they can get infected. And unfortunately, as we age too, our ability to recuperate from things like this is harder. People have a high risk of getting infections, and hospital stays are not great for patients. We get other illnesses in the hospital. So really for hip fractures, that mobility and complications can be pretty debilitating and threatening for patients. Nearly 65,000 women die from complications of hip fracture each year. And half of the survivors are permanently incapacitated. A lot of them do need long-term nursing care as well. So just a little graphic here. On the right-hand side, it kind of shows the general population able-bodied and what percentage of the general population needs to use a wheelchair. On the right, it shows hip fracture patient population and how many people need to use a wheelchair after. So, we really want our patients to have their independence, be able to do their activities of daily living. And so hip fractures are something that we definitely want to prevent in osteoporosis. So I found this cartoon online. I keep finding these all over the house. And my doctor says bone loss is normal at my age. So like I said, bone loss is going to happen. It's happening, to me. I'm over the age of 30. But we need to screen certain populations. So who should be tested? The guidelines for testing are women over the age of 65 years old, men above the age of 70, and then there's some certain populations, younger patients with risk for fractures, which we'll kind of talk about some of the risk factors. Anyone with those fragility fractures over the age of 50, adults with conditions, with a condition or taking a medication that can cause bone loss, and we'll expand on that as well. So risk factors for osteoporosis, like we've talked about, age is a huge risk factor for osteoporosis. Having a previous fracture. So once you fracture, you have a higher risk for future fractures. So this is really important. And, one of the reasons why we screen people after hip fractures and any fragility fracture, because we want to prevent more in the future. Glucocorticoid therapy. So it's mainly oral glucocorticoid therapy, local injections in the back, in the knees, different joints. Those really haven't had clear data that they increase the risk for osteoporosis, but oral prednisone and long-term prednisone definitely is a risk factor. Having a family history, so a parent with a hip fracture and family history of osteoporosis, that's going to kind of determine your genetic curve of your peak bone mass. So that could be a risk factor. Low body weight. So having a low BMI is a risk because, you really don't have too many cushionings on the bones. You're easier to kind of fall in. Or when you do fall, there's more exposure to the joint. So that is a higher risk. Long-term tobacco use and excessive alcohol intake can affect the bones. Secondary osteoporosis, for example, things like hyperparathyroidism, and patients with rheumatoid arthritis and a lot of inflammatory arthritis conditions also have risk for osteoporosis. And we talked a little bit about the peak bone mass. So what happens during a DEXA scan? I don't know how many of you, it's likely that most of you on this Zoom has had one, but it is like a low grade X-ray machine. So the tech will position you in certain ways to look at the hips and the lumbar spine. The data is obtained on the computer, and in our clinic, I look at that data, check it, and the tech generates the report. And one thing I do want to mention is it's very important to get your bone density done on the same machine. This is a picture of a GE lunar machine. I think this is what RMG uses. We use a Hologic, and it's kind of like comparing Fuji apples and Gala apples. They're both apples, but the type is a little bit different. And a lot of the information about your bone density is statistically analyzed, and small changes can make big differences in that. So when we do compare different machines, there is a way to try to compare it, but there can lead to some error. So if you have the opportunity to get a repeat bone density, to really compare those two scans, it's best to do it on the same machine. If you are moving somewhere, bring your prior DEXA scan report. If it is the same, like GE to GE is a little bit better, hologic to hologic, but it is important. It's best to do it on the same machine. All right, so now you've got your bone density done, and how do we interpret what this information means? So basically, I'm going to bring you back to a little bit of statistics in high school or college. So this is a bell curve here. So the center is the average, the median. So and you can see the standard deviations away from the center. So the T-score is how we report bone density. So it's taking your bone density, your bone density score, and comparing it to a young Caucasian 30-year-old female. And if we think back to that original graph, that was peak bone mass. So you're kind of seeing at your best, or at the best that it could be, how far off you are from that. So you can, and that's the T-score. So you can kind of see on here, this is 0, anywhere from -1 and above is normal. So if you're a little bit below average, within one standard deviation, that's interpreted as normal. However, if you're between -1 and -2.5, that's low bone density, previously termed osteopenia. And then -2.5 and below is osteoporosis. So really your kind of T-score, we don't look at the absolute bone density number. It's helpful to look at your bone density compared to a young female to know the difference and the change. So it's kind of written out in T-scores. This is an example of a bone density report. So we do take the bone density in the lumbar spine and either one or both hips, depending on where you're going. And that can depend on the patient. Some patients have hardware in their spine and we can't get some of the information from the spine. And we have to exclude vertebrae. Sometimes there's a lot of arthritis there. And if patients had bilateral hip replacements, we can't really get the bone density of your prosthetic. So we will use the lumbar spine and the wrist. So lumbar spine, and then femoral neck. I think on some of the reports it just says neck, and one of my patients was like, I don't think that they got my neck done, but it's this femoral neck part of the femur leading into the ball and socket part, and that is a place where there can be a lot of fractures. So we take the bone density there, and then the total hip. And you can see they kind of plot it out based on your age, the bone density, and the T-score to kind of see where you are on that curve. And another thing that you might have noticed on bone density reports, so the T-score is what we're looking at, especially in post-menopausal females, but there is also a Z-score, and that, instead of comparing to a young female, it's to your age matched. So if you're 68, it's going to be a 68-year-old female. Not as important after menopause, but if a patient is premenopausal or a male below the age of 50, we have to look at the Z-scores to have more appropriate information. All right. So now you have your bone density back. When do I need to be treated, or what are the indications to be treated? So like I said, going back to that fragility fracture, risk for fracture increases if you've had previous fractures. So if you have one of those, really the bone density is kind of looking at just the severity. So getting your T-score in that situation can help us understand the severity of osteoporosis and decide on treatment. But if you have a fragility fracture in itself, it's an indication to treat. A DEXA scan with a T-score less than -2.5. And the last category is something called the FRAX score. We use this when someone is in that middle, that osteopenia part. So if they have a FRAX score greater than, with a hip fracture risk of greater than 3%, or any major osteoporotic fracture greater than 20%, then that would be an indication for treatment. So I'll tell you a little bit of, more about that, explain more. So this is a tool online. If you just look up FRAX, F-R-A-X, score calculator online, this is what we use to calculate that. It is included on a lot of bone density reports as well. And, you know, the T-score is just based on purely your bone density. And like I said, bone density is one part of bone strength. And so this takes into consideration who the patient is. So age, your gender, your height and weight, so like your BMI, and some of those risk factors, if you've had a fracture, steroids, so you get to plug in all these things. So for this patient, this is 68-year-old female, kind of had risk factor as far as rheumatoid arthritis and using steroids. And the T-score we got from the bone density report. So you can see here, using the algorithm from the FRAX, the major osteoporotic fracture risk for 10 years, having any major osteoporotic fracture, is 24%. And having particularly a hip fracture, and we look at those because of the morbidity and mortality associated with it, is 5.3. So when this number is above 20 and this number is above 5.3 or above 3, sorry, that would be an indication in itself to start treatment. So you can notice here, I used a T-score of -2. That's not osteoporosis. So this is that almost like pre-diabetes, it's pre-osteoporotic, but the risk factors and who the patient is, the risk of having fractures is so high, is that would mean that we should treat the patient. So that's the last kind of category. So I'll kind of go back to the other slide. So if you've had a fragility fracture, the DEXA scan, the T-score just falls in the range of osteoporosis. Or if you're osteopenic with a high fracture risk, a 10-year fracture risk, that can be an indication for treatment. And I don't know if any of the patients that I've met are on the Zoom, and this might be a lot of repeating because it's what we talk in clinic, but, you know, when you're at that 3% mark, sometimes it is, you know, a conversation with the patient and looking at what those particular risk factors are. Is it you're on steroids and coming off of it and stuff? So it all needs to be applied in the context of each patient, but those are the you know, guidelines for treatment. All right, so moving on into the next phase. So you have either low bone density or osteoporosis, and we need to talk about treatment. So some things to help prevent worsening bone loss. So maintaining a healthy weight, weight-bearing exercise, calcium, vitamin D, limiting the alcohol use and tobacco. So these are modifiable risk factors. And then minimizing medications that can weaken the bones. So for the steroids, the risk is mostly when it's oral prednisone greater than 5 milligrams for more than 3 months. So, you know, for me, unfortunately, in my field, I do have to use a lot of steroids. If it's something for RA, we're always trying to get it down as much as we can. But there's other conditions like lithium, seizure medications that really are hard to stop. They're not a temporary medication. Proton pump inhibitors have been studied to have a risk of osteoporosis as well. So, you know, these lifestyle changes can slow down the rate of osteoporosis, but it does not reverse it. So it's kind of, these are things that are going to help, but it's not going to reverse the bone loss that we have. And just to go into a little bit more detail, I get a lot of questions about weight-bearing exercise. So whenever I say it out loud in clinic and I say weight-bearing exercise, I think of Arnold Schwarzenegger in the gym, like that my patients think I want them to be doing deadlifts and be in the gym lifting weights. I would be lost in the gym doing that. I don't do that. So weight-bearing exercise does not need to be that intense. actually having your body work against gravity is weight bearing. So things like walking, climbing stairs, tennis, low grade exercise, dancing, those are things that are great for the bones. Of course, more high impact exercise is going to build more bone, but it's all based on your fitness level. So you shouldn't go above and beyond and strain yourself and put you at more risk for falls or injury. And so just doing something is really beneficial. Another thing is strength training 2 to 3 times a week. So using your body's resistance to work against gravity. This can be, mild Arnold Schwarzenegger. It doesn't have to be, some light free weights, some weight machine resistance bands. Those types of things will be helpful. And then, depending on the person too, if it's balance that is an issue, if they're having more falls, things like Tai Chi and yoga can be helpful. So I did want to pause a little bit here because this talk is kind of given through the PEP classes, and there's a lot of great information on what they can provide for this as well. So I'm going to just take a little intermission here and stop my share so you know what is available for you.
Hi, everybody. My name's Terry, and I am one of the physical therapists that works at our Dignity Health Wellness Center, and I am lucky enough to get to teach some of the classes that could help you, either if you have a diagnosis of osteopenia or osteoporosis, or you just want to prevent having that. As Dr. DiFiore mentioned, weight-bearing exercises are essential, and we have lots of classes that would help in that category. We also have a lot of classes that work on balance. So if you do have a diagnosis of osteoporosis or osteopenia, you definitely want to prevent falling. And one of the things that we find is that when you're afraid of falling, you're more likely to fall. So we have classes to help you improve your balance, and we have classes to help you with your flexibility and your coordination so that you are less likely to fall. So I don't know if you can see my screen, but we have our PEP catalog that I can give you instructions on how to find, and you can give our office a call. And we've got lots and lots of different classes to choose from. And I was just going to highlight a couple that you might find helpful or interesting. So we have a class specific to people that already know that they have trouble with osteoporosis or osteopenia called Better Bones. We have classes that work on your strength and flexibility using your body weight and some low resistance weights, and that's balance, bones, and strength. We have a real fun class called Boxing for Balance and Your Bones. We have Balance Basics, so that it's strictly mostly balance exercises. And we have a balance circuit, so it incorporates training and balance. And then we have a body weight and suspension training classes that we use suspension straps, and you use your body weight to do true strengthening exercises. That's a lot of fun. And then we have strength, balance, and flexibility, other exercises. Dr. DiFiore mentioned Tai Chi and yoga just to keep moving. We have lots of those options. And then we have a whole series of Pilates. And one thing that we have found in research has shown that you want to avoid a couple things at the same time. So all of our instructors know what to avoid when doing exercise to prevent especially spinal fractures if people already have osteopenia or osteoporosis. And most of our instructors are either physical therapists or work closely with our therapy team. So if there's ever a question, we can help. So if you are interested in any of those classes, you could go to our website or give our office a call. And our number, if you want to jot it down, if you have a pen there, is 457-7099. And I'm happy to give you my direct line if you have specific questions, 457-7034. And then our website is also listed on the back of our new PEP catalog, the Focus on Wellness, and it's dignityhealth.org/Dominican/PEP. So hopefully you've all gotten one of those Focus on Wellness magazines in your mailbox recently. We send out thousands of them to our community members, but if you haven't, you have access to it online, or you could always call and we can send you one. So thank you, Dr. DiFiore, for letting me tell everybody some about it.
Yeah.
And I wanted to say that our classes are usually really fun. And even if you're not a hardcore exerciser, like Dr. DiFiore said, a couple times a week to 3 times a week is best. And we make it fun. So there's a lot of laughing and giggling and a lot of other benefits than just physical. So come see us at the Wellness Center.
That's awesome. Yeah, it's always easier to do it with people, right? In a group and get motivated. So that's awesome.
Absolutely.
Thank you so much. All right, let's see if I can go back. Okay. All right. Okay. So now a little bit about supplements. So calcium, it's recommended to take, I usually recommend 1,200 milligrams daily, and preferably from food sources. Something to keep in mind if you are using supplements, the max that can be absorbed is about 500 milligrams and divided. So you need to use divided doses. And I always tell my patients, like, we get a lot of calcium in our diets, like, there's some leafy greens, there's a lot of things in our diet that can incorporate calcium. And the International Osteoporosis Foundation has a calculator online. So too much calcium sometimes leads to constipation. And so I always tell my patient, let's kind of see how much you're actually getting from the normal things that you eat in your daily diet. And then if some supplements need to be added, then that would be best. So I've gotten this question before. Some studies suggest that calcium supplements may increase cardiovascular risk, disease risk. However, it's, looking at the studies and the data, it's still controversial at this time, and it's not very conclusive. Another thing that has been brought up to me in discussing with patients is the risk for AFib, and that also really there's not conclusive evidence on that. So the national organizations, do not really recommend for or against calcium if you have those conditions. But, if there is something specifically with calcium and your arteries, I think talking with the cardiologist would be best. But right now, there's not enough evidence to conclusively recommend against calcium in cardiovascular disease. And then what type of calcium is a question that I get asked. There are different preparations, calcium carbonate and calcium citrate. Carbonate is best to take with meals, and is not great, it's absorbed well if you're on a proton pump inhibitor, and calcium citrate is best in a fasting state. So if you have your bottle and want to double check, but they both work well, but it is something to get the best. If you are taking a supplement, you want to get the best out of it and to know when to take it. Vitamin D. So it's a lot of times low in our patients. So we live in a beautiful area. This year was very hard to get natural vitamin D. I'm hopeful that this summer is actually starting, but there has been low exposure to the sun. And as we age, really getting the conversion of vitamin D through our skin is lessened. And sometimes the foods that are fortified in vitamin D are low in patients. So it's something that is regularly checked by either your primary care doctor or the specialist evaluating you for osteoporosis. The goal for bone health is to have it above 30, but some societies recommend 40 to 60. And the guidelines say at least 1,000 international units of vitamin D3 daily. And if you're deficient, that might need to be higher. Other supplements, magnesium really helps with calcium absorption. One kind of pro trick, calcium, I said, makes you constipated. Magnesium makes you a little softer stool. So sometimes taking them in together might balance the gut in that way. And provided is the dose for men and women. Again, these are natural occurring elements and are in green veggies, legumes, nuts. But if there are supplements, and if you wanted to take supplements, that is some of the recommendations. Strontium, it does show that it increases bone density because it gets incorporated into the bone. It's also found in grains, leafy vegetables, and dairy products, even I guess in some water sources. It increases the bone density, but what it's actually doing for the bone strength is not as clear. So there's no official guidelines from the National Society for osteoporosis, but it is in a lot of the kind of bone health multivitamin, you know, there's like these bone health supplements, and it's likely to be in those. Other supplements, vitamin K, K1 is found in leafy greens. K2 is synthesized by bacteria. And the idea of using vitamin K is that it helps with bone matrix proteins to make them more attractive to absorb calcium. So it's supposed to help with the bone matrix. Right now, it's just observational studies that it might minimize bone loss, but there's no bone density gain. And so right now, again, the two that are very recommended, are clearly recommended, are calcium and vitamin D. These other supplements are in a lot of bone health supplements. I don't think that they're harmful, but there's just not enough information to clearly recommend a dose and you know, to have it as a clear guideline. All right, moving on to medications. So if you do require medications, there's two big classes: anti-resorptive medications and anabolic medications. So on this side, it's probably a lot of familiar terms. Alendronate is Fosamax. That's the oral form. Reclast is the IV form of the bisphosphonate. There's Prolia. And some of these newer medications, anabolic medications that really build up bone fast and are used in severe osteoporosis. So I'll kind of go through these a little bit more. Bisphosphonates have been around for a long time. And typically I use the Fosamax pill form. So this is a weekly, I usually do the weekly 70 milligram pill. Or for the IV infusion, it's 1 yearly infusion for this type of bisphosphonate. There are side effects of these medications. So in the pill form, one of the common things to discuss is pill esophagitis. So if you have trouble swallowing and or you know, really bad reflux, this pill is big and you have to stay upright. You have to drink it with copious amounts of water because it can kind of irritate the esophagus or the feeling of it getting stuck. So that's one thing to take into consideration. And then specifically for the IV form, the Reclast, about 12 to 48 hours after the infusion, some people experience flu-like symptoms. So am I coming down with something? My muscles ache, I feel tired. And that can last up to 2 days. So it is something that I warn my patients about. It is, you can have more muscle aches and joint pains after the infusion. It is temporary. It should not persist, but it is, you know, kind of alarming after an infusion. Both the oral and the IV form it can cause hypocalcemia, and you should caution with these medications. If you do have kidney impairment, you should talk to your doctor to make sure that, depending on the severity of your kidney impairment, if it's safe to take the medication. So one of the main things that gets everyone's attention is osteonecrosis of the jaw. And I elected to do a nice smiling picture so we have something nice to look at while I discuss this. But I always tell patients, if anyone looking at pictures online, try not to go deep down in the depths of the internet. But yeah, it is something that is not the most reassuring thing. So once you see pictures of it. So what osteonecrosis of the jaw is exposed bone in the jaw that doesn't heal within 8 weeks. So if you have been on a bisphosphonate and you're having dental work, you know, and the dentist is unaware, there is a very small risk that the bone will not heal. So osteonecrosis means, you know, death of the bone. The thing is, it is a very, very low incidence. So you can see here that it's 0.001% to 0.01%. So in oncology, they kind of use bisphosphonates in different ways that are more frequent or higher dose. So the risk is a little bit higher. But for osteoporosis, the way we dose the medications, it's a very low risk. So I try to put that in the mind of the FRAC score, the risk of having a fracture in 10 years is 20%, and so when we're balancing the risks and benefits, realizing that this is a very low risk side effect, but yes, there is the side effect of this happening for patients on the medication. While you are on bisphosphonates, you should get a routine dental exam. And if I'm talking to a patient and we're thinking about initiating the medication, we just wait until all the dental work is done. If you've had dental implants in, it should be fine. It's really the, active drilling into the jaw. And it really requires good communication with the dentist and the prescribing doctor. I talked to a dentist last week to confirm with the dentist about the procedure, if they felt safe about, them being on the bisphosphonate as well. And sometimes you delay the medication for 3 months. You hold it, so you stop the medication for 3 months to a year. However, there's not even great evidence on how long or to do this. Like, the studies are still lacking, and the medication does stay around for quite some time. So I think the reassuring thing for both dentists and physicians is that it's a very, very low risk. And so we try to do our best to mitigate as much of the risk as possible by having dental exams regularly and getting any known work done prior to starting the medication. The other thing that I want to talk about is atypical femur fractures. So this can be something that is seen on bisphosphonates. So it's pain in the anterior thigh or leg area. You will have kind of like a dull aching pain, and it can happen on both sides. So this risk is really with prolonged bisphosphonate use. You can see here that the incidence after 3 years of using a bisphosphonate is 0.01%. However, that does go up to 0.1% after 10 years. So looking at these studies, we do what's called a drug holiday. So it's important to continue to communicate with your physician about how long you've been on these medications, because we need to give them a break, no pun intended, off the medication so we don't have this risk. So basically how I describe it is that you're on the bisphosphonate for a long time and it's building bone, but it's almost too dense and it doesn't have the right integrity. And so it leads to atypical fractures. So typically somewhere around the 5-year mark, we come off of the bisphosphonate, and I think the absolute is 10 years, but I probably want to go more than 5. So it is something that if you're on a bisphosphonate and you're having atypical, like it's not in the hips, it's more in the thighs, it's best to let your doctor know, and we get x-rays of the hips. If we want to kind of find patients in this area where there is a little bit of peaking of the bone here, and you can talk to the orthopedic doctor, but we don't want people to have fractures. Again, I always tell my patients, I'm not a great saleswoman. I want you to know the information about these side effects of medications. The thing is these are very rare, and when we focus on the side effects, we are missing the opportunity to prevent fractures. And so I think being aware of some of these side effects to know what symptoms go along with it, but they are, still safe medications to use for osteoporosis. On that note, I'll try to, I still have a couple more slides. I see it's 6:17, so I'll try to keep it going to save time for questions. But another schematic to visualize this. So this is out of 1,000 people on osteoporosis medication for 5 years, less than 1 will have osteonecrosis of the jaw, and less than 1 will have atypical femur fractures. But on the converse side, the risk of fracture without osteoporosis medication, 500 will suffer a fracture if you're not treated. So it's hard, like I said, seeing the pictures or even seeing the x-ray can be shocking, but it is really important to think about these risks and the statistics with these medications about the side effects and realizing that they are very low. All right, couple more medications. Denosumab is Prolia. It is also a different anti-resorptive medication. It is given in office intramuscularly every 6 months. The thing that I discuss with patients for this, it's really important to give on time. You want a steady state of the medication in your system because when you're off of the medication, they found that there were these rebound vertebral fractures. So during the pandemic, when everything shut down, we didn't know what was going on and people missed their, Prolia injections. And I think there was a little uptick in vertebral fractures. So this is something for patients, if you're traveling or going between two homes or whatever it is, and if you can't really consistently get an injection every 6 months, it's really not the best medication because you're actually increasing the risk of fractures in some way. It is something that if you wanted to come off of it, you would have to transition to a bisphosphonate medication to maintain the bone that was built with Prolia. You also have to monitor for hypocalcemia, and this also has a risk for osteonecrosis of the jaw and atypical femur fractures. I told you for bisphosphonates, it was low, very, very low. This is very, very, very low. So I guess the incidence is just even lower, but yeah, it still has a small risk. And it has a mild risk for infections as well. The last big class is anabolic agents. So these are the ones that build up bone very quickly, and they are used in patients that have very high risk of fracture. So usually that is multiple vertebral fractures with a bone mineral density less than -2.5. If you fracture while you're already on a different therapy or a T-score less than -3. They are parathyroid hormone analogs, and these are things like Forteo and Tymlos. Their side effects is hypercalcemia, and it had a warning of osteosarcoma in rats, but it was not shown in humans. I think it did have a black box warning in the past. So if you have any, history of osteosarcoma, you should check with your doctor first. I think within the last 2 to 3 years, there's been one more medication called romosozumab or Avinity. And I have not actually used this medication yet because in the last year or so, I'm COVID time, I've lost track if it was a year or more. There was a black box warning for risk of heart attack and stroke and cardiovascular death. So right now, they said, looking at the data, if you've had a stroke or a heart attack in the last year, you should not use this medication. Honestly, I think I would try to use the other ones, the Forteo or Tymlos, but it is something I want you, if this has been brought up to you by another provider, it should be a conversation that you're having with them, especially if you have risk for cardiovascular events. All right, so saved about 10 minutes. I'm sure there's lots of questions, but in closing, fractures due to osteoporosis are preventable if osteoporosis is identified and treated. So get screened, get your bone density done, and talk to your doctor about what medications you can use and the preventative measures as well. There are many options to treat osteoporosis. They are safe and effective, and kind of realizing that those somewhat seemingly scary side effects, they are very low, and to be aware and discuss with your doctor how you can monitor and look out for them while you're on the medication. So with that, I will stop sharing my screen and open it up to, if there's questions in the chat or if anything came to mind when doing the talk.
Great, thank you so much, Dr. DiFiore. Fantastic talk. And several of you mentioned about the slides, and we will be able to send them out in the PDF format. But a couple of questions that came through. One is the use of SSRIs a risk factor?
For osteoporosis, Not off the top of my head. I can confirm that, and I don't know if, but it wasn't, when I was doing my preparation for the talk, it was not. So good question though. That's a very common medication, but not in particular one that I look out for.
Okay. All right. And then a couple of other questions. One was about the reclassed infusion, and I don't know if you mentioned that. I may have missed it, but
yeah, was there, so I think the first one was that it's scary, and you know, I think in general, you know, a lot of these things are conversations with the patient to kind of provide this information, but the infusion, it goes pretty quick, and the main thing to think about, particularly for the IV infusion, is that kind of feeling like you're coming down with the flu symptoms. I don't know if there's something else in particular about the infusion that there's questions about, but that is the main difference than taking the oral pill weekly. The other good thing is if you have any problems with gut absorption, the IV infusion is really getting in to your system. You know, if you're taking the alendronate, sometimes we don't know how much is being absorbed. And so that's a nice thing about the IV infusion.
great, thank you. And then one other question was, how is biphosphonate related to the 8 meds in the chart? And I'm not sure if that's a specific enough question.
I think I can, might have been just my terminology in describing some of these things. So let's see, I think I use different terms. So I can share my screen one more time if I can get my mouse on the right screen. So bisphosphonate is the where am I mouse? So are these listed medications? So it's a certain class of anti-resorptive osteoporotic medication, and it's just the way that it works. This is the denosumab is a RAGE ligand inhibitor, and then these are PTH and receptor analogs. And then I think romosozumab is an anti-sclerostin. So it's just how they are working. On the next slide, I think it's just another table saying the same thing, but it's showing the different types of bisphosphonate medications.
Great, thank you. And then a couple more questions have come through. Does thyroid medicine, levothyroxine and bone have a correlation or connection?
Interestingly, it's hyperthyroidism that has a connection for osteoporosis. Hypothyroidism is more common, but it's hyperthyroidism that can be a risk factor for secondary osteoporosis. Oh, I think you're muted.
Sorry, and the medicine, the levothyroxine, is that does that have an effect on bone loss?
No, I think it's more of when it comes up in conversation with patients is when you know, you're taking the medication in the morning, like empty stomach, and to do both, like if you're on alendronate, but not to my knowledge, no.
Great. And that leads into the next question. Should oral treatment be avoided for a person with a stomach ulcer?
I think yeah, it's the esophagus is really where the pill gets stuck. But if you're having if the stomach ulcer is due to really bad reflux, that can kind of affect the esophagus as well. I think that I would consider doing the IV for that, because I don't think it's necessarily going to worsen the ulcer. It's just more of going to be difficult to take the medication.
Great, great. Well, I think that answers all the questions in the chat. I just want to thank you so much for joining us. What a great wealth of information. If any of you have further questions, you can please just email us at the Wellness Center. And I'll share my screen right now and let you know what some of the upcoming classes we have. In a couple of weeks, we have an author talk on joint health. And then in August, we have an Alzheimer's forum. And then we have another talk on healthy living for your brain and body in September. And then in October, we have a senior health fair where we're hopefully going to be covering most of the topics, including oncology and orthopedics and spine, general medicine, cardiovascular health. So we're excited about being able to bring you those. Again, if you have any other questions, please don't hesitate to reach out to us and check our website, or give us a call at 457-7099 if you have any other questions about some of the classes that Terry talked about. So with that, Dr. DiFiore, again, just thank you so much for your time. That was a wonderful talk and great deal of information. Thank you so much for all your great work.
Thank you. Thank you for everyone for coming to the talk and providing the opportunity to talk about this. So
great. Well, have a great evening, everyone.
All right. Take care.
Bye-bye.
Bye.